Hey everybody, welcome back. Today I want to talk to you about patellar chondroplasty, which we already introduced when we talked about articular cartilage lesions of the knee. So if you remember, in the previous recording, we discussed the entire knee, and then the rehab was actually more focused on when surgery is done at the femur, the distal part of the femur. So if you remember, we looked at this picture, and you can see that white cartilage, that beautiful smooth cartilage of the distal part of the femur and the back of the patella. And both of these areas can end up with cartilage damage. And so we talked about surgeries that would be appropriate for both, and then we did rehab, specifically more related to the distal femur. But what you're going to see is that a lot of crossover occurs. Specifically related to the patella, we can have microtrauma, so small repetitive patella pain that can lead to cartilage breakdown, but we can also have macrotrauma, so things like a patella dislocation, which this picture shows very elegantly, can also lead to larger holes or injury specifically to the cartilage on the back of the patella. If there's any issues with osteoarthritis, then oftentimes we're seeing that the cartilage is damaged. And so we talked about that a lot when we talked about total knee replacements. And so unfortunately, when we get this trauma to the back of the patella, that can lead to early onset osteoarthritis. So again, this is just showing you those pictures, cadaver pictures, where you see that nice, beautiful white cartilage, nice smooth cartilage on the back of the patella as well as the distal femur. And what we really need to think about is that cartilage on the back of the patella and how it articulates with the femoral groove. So we know that the patella is providing a nice kind of fulcrum for the knee to bend well. And if that patella is causing too much pressure on the back of, on the femoral groove, then we oftentimes can get breakdown of the cartilage on the patella. So I don't want to go into a lot of detail about the kinesiology behind this, but just recognize that if you're working with patients who have patellofemoral pain, oftentimes what's happening is that we are getting too much pressure of different aspects of the patella against the femur. And if patients are not fully extending their knee, then they're not getting any pressure taken off of the patella throughout their day. So if their knee is in a lot of flexion, like A, or even just a little bit of flexion, like B, then you'll see that the back of the patella is pressing up against that femur. But then when you go into full extension, we actually have relief of the femur, the patella pressing on the femur. And so it's important that we spend a lot of time talking about extension. And we did that with the previous presentations related to the knee. And it's important, again, when we're talking about cartilage damage to the patella and then surgery following this damage to the patella to help with getting that cartilage to regrow. So when we see this significant cartilage damage, tends to be in younger people, especially if they've had a dislocation. But what surgeons also find is that a lot of people just going through any type of arthroscopic surgery around the knee, if they were to look at the cartilage on the back of the patella, they would find some degeneration. So that's very common. And what they've found is that this cartilage damage can happen to 37% of all athletes, with the most significant damage happening in runners as well as basketball players. So again, those people that probably aren't getting full knee extension very often, and so they're causing a lot of pressure along that femoral groove. Just like when we talked about the distal femur, the diagnosis is primarily done with some sort of imaging. And again, if they're doing arthroscopic surgery for other reasons, then they might also recognize that there's damage, might decide that they need to fix that as well. So these are the patients that complain of anterior knee pain, as I said, that chondromalacia, patellofemoral pain, all of those kinds of things. So we're not going to go into a lot of detail about that. But what we recognize is that those patients oftentimes have issues at the hip. And so we're going to see that internal rotation and adduction that's coming from the hip. And then you watch things like an eccentric step down or a squat, and you can see that significant internal rotation and adduction, which again, the idea is that is not allowing the patella to move correctly in that femoral groove. And so we need to figure out ways to help the patient, again, find muscle balance and a better alignment. And so what we recommend is performing things like the Thomas test, the Ober test, checking muscle length of the gastrocsoleus complex, so dorsiflexion, to make sure that we're allowing for good movement through the movement during weight bearing, and then also checking muscle strength of the glute min, the glute medius, the glute maximus, sometimes tibialis posterior, peroneal muscles. So again, this is all the things that we've talked about with lower quarter rehab. You're looking at all of those things to help with getting better alignment so that the patella can move correctly. You also want to let the people know that it's going to usually take about 6 to 8 weeks. I think we kind of already know this. We've talked about it before, that for for lower extremity strengthening, we need to recognize the time frame is going to be at least 6 to 8 weeks to get those muscles to turn on correctly, and then continue to increase strength of the muscles that are weak. So we can use other types of assessment things to look at for more of our high performing patients. So our athletes, we need to, again, probably return to running, to jumping. And so we can use things like the timed up and go or 6-minute walk test for our lower activity level people, but for our higher activity, we're going to be using some sort of hop testing, like the single limb hop tests here. We'll go into detail a little bit more with this stuff when we talk about specifically return to sport following ACL repair, but just recognize that these are some things we need to use as assessment for our non-op and our post-op for return to sport or just return to normal activity. We're also going to do some sort of movement assessment. Again, this is in much more detail elsewhere, but just recognizing that we need to be watching these things for alignment and knee control. And then we can use these same things for treatment. So this movement assessment then becomes what we can use to help with alignment for treatment. Patients tend to end up getting surgery if they're young. So like we said, the patient population that we're going to likely see after surgery is going to be a much younger person. If they're over the age of 65, then they're more likely to have some sort of replacement or do conservative treatment. But if they're under the age of 40, especially athletes, we're definitely going to consider performing the surgery. So the technique is, again, they're very, very similar techniques to what we saw with the distal femur in the previous presentation. So basically they will tend to do microfractures very regularly, as well as doing some sort of ACI type of surgery like we talked about before. So here's a video that shows you what to expect from these surgeries. Recognize that usually at least 50% have a good recovery rate and get some relief with any of these surgeries. But it's hard to know whether or not they may require a second surgery. So it is possible that these people, they don't end up getting enough cartilage growth and they do have to go in for a second surgery. But let's just take a look and see kind of what this surgery looks like. Again, it's going to look very similar to what we talked about with the articular cartilage problems at the distal femur.
The patella is a flat, triangular-shaped bone that protects the knee joint and helps muscles move your leg more efficiently. A healthy patella glides up and down a groove at the end of your femur, pain-free. However, there are a number of conditions that can cause pain when your patella moves. Your surgeon will determine which treatment is best for you based on your specific condition. Small incisions are made around the joint. The scope and surgical instruments will go into these incisions. The blue arrow is indicating the area that will be treated during this procedure. The scope is inserted into the knee. Saline solution flows through a tube and into the knee to expand the joint and to improve visualization. The image is sent to a video monitor where the surgeon can see inside the joint. The damaged cartilage is removed from the joint using a specialized surgical instrument. After the damaged cartilage is removed, a drill or pick is used to make small holes in the exposed bone. Making these small holes will help heal the damaged area, thus the term drilling microfracture. After the drilling is finished, the surgical instruments are removed and the procedure is completed.
Okay, so complications are very similar to what we saw, again, with the distal femur. So cartilage breaks down more quickly, unfortunately, with the back of the patella, and so we tend to not have the best results with this surgery if people get too active too fast. Also, patella stiffness, knee stiffness, decreased flexion tolerance, those things are also complications. So we already talked a little bit about the rehab for the patella in the last one, and we talked about the weight-bearing status and things like that a little bit. What you want to recognize is with this surgery, the first phase lasts usually about 6 weeks. If you remember, usually in a straight leg brace so that they don't flex their knee and end up with pressure of the patella against the femur. So during this first phase, we really want to start showing them how to do their gait with that type of knee extension. And then our primary goal is to control pain and inflammation, which you'll notice is going to happen as a goal with pretty much every single one of these kinds of patients. It's pretty consistent. So weight bearing is tolerated. They really should be able to weight bear is tolerated, but when they're walking, they should have a brace that can be locked into extension. So they can allow for flexion with sitting and non-weight bearing, but when they're weight bearing, they should be using that extension brace. The CPM is also recommended with this group, but you'll see it's 6 to 8 hours per day. And that's supposed to help with that synovial fluid getting in and out of there and helping to get the cartilage to heal more properly. CPM has a little bit more specific instructions with this patient population to not allow too much flexion initially. So what they're saying is 0 to 40 degrees initially, and then you can increase by 5 degrees per day. And so you're going slowly and you're increasing of flexion during this time. Also, we want patients to know that it's going to take 4 to 8 weeks before the pain decreases significantly. So they should recognize that the first 4 weeks or so are going to be pretty painful, and doing that flexion is probably going to be pretty painful. Treatment is going to focus on active range of motion. And active range of motion, again, going as slowly as we were doing the CPM. So kind of following that rule for active range of motion into flexion. But we also want to be doing isometrics for quads and glutes. So again, knee extension is important. Most patients do just fine with knee extension, but may have a hard time turning on their quadriceps. So that becomes a huge part of our initial treatment, which again should look kind of familiar. It was very similar when we talked about knee replacement. It was very similar when we talked about the patients after distal femur articular cartilage repair. So starting at about week 4, we can do very, very gentle superior patellar glides, just superior. Again, Superior is what happens with knee extension. And so we can definitely allow for that to happen and be very gentle with our mobilization starting at week 4. So by the end of this phase, remember this phase goes for about 6 weeks. By the end of the phase, we should be able to see very active and good quad contraction. We also should have full passive knee extension, and we are going to start walking more and allowing the knee to flex. So again, at about 4 weeks, usually most surgeons will allow for some flexion in that brace during gait. And so we're going to want to start doing that and allowing for that flexion control to start happening. But it becomes the big focus during our second phase. So the second phase is going to last from week 7 to week 12, so about 3 months. And it's during this phase that we do want to have full range of motion at the hip, the knee, and the ankle. So again, it's important that they are allowed to weight bear early, even if they're wearing a brace and knee extension, because it allows for us to keep our dorsiflexion at the ankle and hip extension and things like that at the hip. So then as we can start working on more knee flexion during this phase, we shouldn't have to worry about ankle dorsiflexion. We shouldn't have to worry about any mobility at the hip. So during this phase, we're definitely continuing to use the brace. So if they're walking a lot, if they're spending a lot of time in weight bearing, then they need to be wearing that brace. For short distances and periods of time, it's fine to not wear the brace. But then the other really important patient education is to avoid twisting and pivoting. So they should not be planting their foot and turning at all during this phase. It's really important because, again, we don't want uneven wear of the patella pushing against the back or the femoral groove. So we want to cycle. This is, again, another great patient population that cycling would be appropriate. So 20 minutes a day with little resistance at this point. We also want to make sure that we're spending a lot of time on gait training and allowing for that knee flexion to happen during gait training because they're going to be fearful of knee flexion at this point. Patellar glides, again, superior, inferior only. We don't want to do medial and lateral where they would be pressing that patella up against the femoral groove. We really don't want that. So we are really just spending most of our time inferior, superior to allow for flexion and extension. And by the end of this phase, we really don't want any extensor lag. So they should be able to do a straight leg raise with their knee fully extended, their quad turned on, and no flexion during that straight leg raise. Okay. We also want the knee to look, the patella to look stable with basic normal activity. So during walking, during small squatting, we need the patella to look normal, and we want flexion to be at least 120 degrees. So we say full range of motion, but as long as we're 120, it should be fine. They also should be able to tolerate single leg stance and demonstrate very minimal swelling. But again, at 3 months, there is probably going to be a little bit of swelling still in that knee. So the third phase is weeks 12 to 24. So we're going up to about 6 months for this one. And our primary goal here is to return to ADLs, to return to being able to do normal daily activity. They should be able to climb up the stairs to get into their apartment. They should be able to go to the grocery store and bring home groceries, those kinds of things by the end of that 6 months. And we're telling the patients, we're educating the patients on not trying to do significant amounts of stair climbing. So don't go up and down the stairs as exercise. But again, if you need to go that way to get in and out of your apartment, that's fine. We also are discouraging open chain resisted activities for 6 months. So closed chain is okay, just like we talked about with the previous patients, but open chain resistive exercises you want to avoid because, again, it just causes a lot of pressure on the patella and not very good options for tracking of the patella. Also, by 6 months, pain relief should be significant. So it's going to take maybe that long. Like we said, 3 months, significant pain, and then it should start to get better so that by 6 months they're feeling a lot better. Elliptical training, we talked about this with the last patient population with distal femur, articular cartilage surgeries. I love the elliptical because, again, it allows for more upright, so it kind of reproduces a running motion, but it's a lot less loading. Closed chain activities, we said those are great. In all directions, it's fine, but just make sure that they're not going more than 90 degrees of knee flexion. Ladder drills, things like that are also okay. And at about 5 months, we can start running. So running is appropriate. So then we're also doing a little bit of jumping and things to allow for running to happen. We want their strength to be at least a 4+ out of 5 at this point. They should have full knee range of motion, and they should be able to perform more advanced eccentric activities like a step down or even, like I said, a little bit of jumping and hopping without any issues of knee control, lower extremity alignment issues, anything like that. They also should have minimal swelling at 6 months. So return to sport for these guys, again, remember a lot of these patients, their primary goal is return to sport. That's not going to start until about 6 months. And with that, you can use the hopping and jumping assessment tools that we discussed earlier in this presentation for our non-operative patients. And at this point, you're going to start doing more higher impact activities and more lateral movements, cutting movements, and things like that at about 12 months. So they can start running earlier than 12 months, but we're just staying within sort of the sagittal plane of running. We're not increasing our lateral movements. We're not increasing lateral jumping and those things until 12 to 18 months. So there's a couple references for you guys. This one's pretty quick because, again, it looks pretty similar to the previous presentation. So if you haven't listened to the articular cartilage of the knee repair presentation that I did before this one, make sure you listen to that one because I go into a little bit more detail in that one. Okay, talk to you guys soon.